Welcome to Personalizing the Management of Advanced Gastric Cancer, presented by the University of Nebraska Medical Center, Center for Continuing Education at OMED Live. My name is Dr. Kelsey Clutie, and I'm a clinical fellow in medical oncology at Weill Cornell Medical College. I'm moderating on behalf of Dr. Chandra Are, who's unable to be here due to the weather. We thank him for his contribution to the program. Activities on OMED Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Manish Shah, Director of Gastrointestinal Oncology at Weill Cornell Medical College. Dr. Shah is a recipient of the Bartlett Family Associate Professor for Gastrointestinal Oncology Award. Manish, thank you for joining us today. I'll now hand the program over to you to begin our discussion.
Thank you very much, Kelsey. I'd like to talk about personalizing the management of advanced gastric cancer. I'd like to thank OMED for inviting me and Dr. Chandra Are, and thank you for filling in. So first, we'd like to talk about some background epidemiology. Gastric cancer is a prevalent disease worldwide and accounts for nearly 1 million new cases every year. About 10 to 15% of all gastric cancers actually have a hereditary predisposition. Hereditary diffuse gastric cancer accounts for 3 to 5% of the cases and is caused by a germline mutation in CDH1. Lynch syndrome with mismatch repair deficiency also accounts for 1 to 2%. And then less common germline causes of gastric cancer include FAP, Li-Fraumeni syndrome, and Poitsiacre syndrome. There is significant global heterogeneity of the disease. The disease is more prevalent in Asia. There's significant worldwide variance in H. pylori, more common in Asia and developing countries, and less common in industrialized nations. In the US and in the West, when patients present with a disease, it is often in a more advanced state. And there may be a difference in underlying biology between the various areas. Then we also know that gastric cancers and esophageal cancers cannot be treated as one disease. There are differences in histology. For example, in gastric cancer, we think of intestinal type or diffuse type. Differences in location, so proximal tumors behave differently than antrum tumors. Biology may be important with regard to either CDH1 mutation or MET mutations. And then etiology. Many cancers are related to chronic infection with H. pylori, but there may be other etiologies as well. So we've developed a construct of genetic risk, environmental risk, and behavioral risk. Genetic risk includes the things I've mentioned already, CDH1 mutation, mismatch repair. Environmental risk includes H. pylori, specifically the CAG-A strain. And then behavioral risk, so tobacco and a diet heavy in salt increases risk for gastric cancer, whereas fruits and vegetables reduces your risk. Here is our first anonymous polling question. A 67-year-old gentleman presents to the emergency room with a 30-pound weight loss and dysphagia. He is very weak and fatigued. He is found to have a bleeding gastric antral mass with a visible vessel. His hemoglobin was 6.3 grams per deciliter, and CT scans show no evidence of metastases. What is the best approach? Is it A, endomucosal resection of the gastric tumor? B, proceed with laparoscopy, and if negative for metastases, distal subtotal gastrectomy followed by adjuvant chemoradiation. C, preoperative epirubisin, cisplatin, and capecitabine followed by surgery, followed by the same treatment postoperatively. Or D, preoperative docetaxel, cisplatin 5-FU, followed by surgery, followed by postoperative DCF as well.
So this is an interesting question. Is this a common presentation for patients with gastric cancer?
I wouldn't say so common. I think 30-pound weight loss and dysphagia, people do tend to present a little bit earlier, but it's not uncommon. The stomach is kind of a sanctuary site. People often have weight loss or GI symptoms. They don't really know what it is, and they just live with it for a while.
And what impact does the weight loss have on this patient's overall prognosis?
Well, the main drivers of his prognosis are the extent of disease. If the disease is localized, then there's a chance that we can remove it, give perioperative or adjuvant therapy, and still cure the patient. However, I think the weight loss does signify significant malnutrition, which may increase toxicity both to chemotherapy and surgery.
Okay. And what about toxicities related to these chemotherapy regimens that are listed, like ECX, DCF? How are they tolerated?
Yeah, so the more drugs you add together, the more side effects you're going to get. DCF is a pretty toxic regimen, at least the way that it was originally devised. So many modifications have been pursued for that. ECX is pretty well tolerated, especially now that we can use capecitabine instead of infusional 5-FU.
Great. So 75% of our audience chose option B, which is the correct answer.
That's great. I think that's an important point that people realize, that the patient had an active bleeding vessel with a hemoglobin of 6.3. He was really in an unstable condition, so he wouldn't have been a good candidate for perioperative chemotherapy. I think that we really need to proceed with addressing the tumor itself. The endomucosal resection is unlikely to be useful because the tumor is a little bit more advanced given the way he presented and the visible mass on the CT scan. So back to the presentation and gastric cancer. So the Cancer Genome Atlas recently published an important finding based on molecular annotation of over 200 gastric cancers. They've identified 4 major subtypes: the Epstein-Barr subtype, which is responsible for about 10% of gastric cancers, the microsatellite instability subtype, the chromosomal instability subtype, and the genomic stable subtype. And we see already that many of the gastric cancer subtypes that we defined earlier actually do fit into these categories. For example, the genomically stable subtype of gastric cancer is predominantly diffuse. The MSI and chromosomal instability subtypes are predominantly intestinal, and they have varying levels of mutations and methylation status. And then the EBV subtype is very interesting. It tends to be hypermethylated and actually also overexpresses PD-L1 and PD-L2, which may be important targets for future studies. So this is a very busy slide talking about the different gastric cancer the different targets that are being explored for cancer treatments. So we can see at the very top MET and EGFR and HER2. These are all pathways that provide growth signaling to cancer cells and avoid apoptosis and improve survival, and they are active cancer targets. And then downstream signaling such as RAF or MEK or AKT. So many of these different targets are actually in clinical trials now, and our challenge over the next 15-20 years is how to best identify which patients will benefit specifically from which drugs. As we learn more about the biology of gastric cancer, and specifically the different subtypes of gastric cancer and the types of mutations, we may be able to target our drug discovery in a much better and more refined way. So there are ongoing studies in gastric cancer worldwide. We are examining MET inhibition with large phase 3 studies, HER2 inhibition, both in the first line and second line setting, EGFR inhibition, anti-androgenic therapy, STAT3 as a indicator or inhibitor of stem cells or stemness, and the immune checkpoint as well. This is a very exciting time from a cancer treatment standpoint because we have more and more options for our patients, and hopefully some of these studies will pan out and come to fruition. So the first targeted therapy I'd like to talk about is trastuzumab. This is the schematic for the TOGA study, in which patients were randomized to receive chemotherapy with cisplatin and fluoropyrimidine, either with or without trastuzumab. So about 20% of patients are HER2 positive, and when you receive trastuzumab with chemotherapy, you see a significant improvement in survival with 13.8-month median survival in this study, whereas it was only 11 months with chemotherapy alone. And in the highly overexpressing tumors, survival was even further at 16 months, and that's shown here. So this is the forest.